Well, good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar that's sponsored by Salient Healthcare with special guest host, Mingle Health Solutions. And it is titled Digesting the Alphabet Soup of Medicare's Final Rule for 2023, APP, MIPS, MVPs, and more. Very excited to hear from our speakers today, which I'll introduce in just a moment. A few items of note before we get started. First of all, everyone has joined today in listen-only mode. This is a traditional webinar format, so you don't need to worry about your microphone or your camera. That's been done for you. Secondly, we do want to hear from you during the webinar, so please ask any questions that you might have. We will have a time for Q&A toward the end, but you don't have to wait until the Q&A in order to ask your question. So go ahead and ask it at any time, and then we'll get to as many as we possibly can during the Q&A time toward the end. And the way you do that is you have a module as an attendee that has a little area for questions. You also have chat, but go ahead and ask it in the questions, and that way we can make sure that we get to it. And again, we'll get to as many as we can. And then finally, today's webinar is being recorded. So you're going to have the opportunity to rewatch it and share it with colleagues, and we hope that you do. And so what's going to happen is when we're done, I'm going to send out an email to everyone who is registered, even those who haven't attended, and there will be a link to the recording, also where you can download the slides from today's presentation, as well as get in touch with them, and there'll be some more information there as well. So without further ado, I wanted to introduce our speaker today, who's Dr. Dan Mingle. He is the executive chairman of Mingle Health Systems. So Dr. Mingle, I'm going to bring you up now. On camera, he's coming. There he is. Welcome, sir.
Good afternoon, Garrett. Great to be here. And good afternoon to everyone who's joining us. Great to see you again. I hope there's some new faces out there. I've been in a routine habit of visiting with you at least twice a year with the proposed rule webinar and then the final rule webinar. So let's see where we go with this today. This is all about us. I'll give you a moment to read that, but won't bore you with those kinds of details. And all about me, I am a family physician. I'm the founder and executive chairman of Mingle Health. Been doing quality reporting, other electronics, and utilization of the EHR for a few decades now. And this is all about the 2023 final rule for the physician fee schedule, which also gives us the new rules for the quality payment program, including the merit-based incentive payment system and the Medicare shared savings program, which were the big items in the rule this year. We're going to tell you where to find resources, review the major elements, then hit some of the MIPS topics, and then the shared savings program topics, the highlights individually. First, repeating what Garrett had to say, you can find the slides and the recording in their library, or you can go to the Mingle Health website and get it in our resource center. And also for more resources, Medicare is doing a bang-up job, I think, of documenting the programs and the rules much better than they did a couple decades ago. So qpp.cms.gov is the place to go. They have a resource library there. In the middle of the page, when you go to the full resource library, is this search screen. Put in final rule and you'll get these two links coming up. The final rule takes you to the Federal Register. The others are somewhat redundant, but very clear, repeats the right thing, so you get the important stuff, but some nice resources to understand what's new in the rule. Interesting rule. This, I think, in my experience, is a more strategic rule than others have been. It's not kind of understated was the usual increases to make the program a little more challenging every year, and all that housekeeping is in there. But there's a couple strategic stakes they put in the ground, which are really important and very interesting. So I'll hit on those. They reiterate the fact that they want 100% of Medicare beneficiaries to be in an accountable care relationship by 2030. Now, I think that's an aggressive plan considering the pace, and I think it's going to involve some reanalysis or redefinition of what accountable care is, and also you can see in these other strategic plans that we're going to see some more interplay between MIPS and accountable care that perhaps makes it credible that anyone seeing a provider that's in the QPP, and that's most of us, will be providing accountable care. And they reiterated that the intent of the whole program is to use MIPS to train and introduce providers to value-based concepts and to encourage them to migrate into advanced payment models, particularly the MSSP, which has become a program on its own, not just a CMMI, a Center for Innovation project anymore. It's got a life and potential of permanence with some migration every year. And health equity this year shows up in the rules with a fairly strong showing, and I'll go into the details there. In MIPS, MVP is finally here. MVP starts, you can choose to participate through MIPS value pathways starting with the 2023 performance year. Also, only 12 MVPs to bear for you, and I'll just show you the list here shortly, but again, look at the details in the QPP program. Planning for the sunset of traditional MIPS. Now, this was a strong statement. I think it was implied in previous years, but now they're saying that they're expecting traditional MIPS to come to a close, what we're doing now, and we'll go to this new MIPS, which they intend to be fully based on MVPs. And I'll show you that in a moment. So with a proposed sunset, not set in concrete at all, we still subject to final rules, to annual rulemaking, but at the moment thinking that 2027 may be the last year of traditional MIPS, with MIPS based on MVPs to start in 2028, with MVPs being mandatory, in fact the only choice, and mandatory subgroup formation. MSSP is also in the 2023 final rule in a big way. In fact, there's nearly twice as many pages devoted to the MSP than to MIPS this year, turnaround from usual years. So anticipating still the sunset of the web interface after 2024, and showing, kind of quoting a legislative requirement that they gradually increase the challenge inherent in the programs, the expectation of the programs, and being one of the reasons why they're advancing that. With full-on APM performance pathway, that is the requirement to use the MIPS or the electronic CQMs starting in 2025, with an option to do it in any of the years prior to that. Mandatory at starting in 2025, all patient, all payer submissions using those CQMs. They're also expanding the incentives for early use of the MIPS CQMs and eCQMs. They had previously given a break on the quality standard, and they've expanded that a bit and also extending it into the 2023 and 2024 years. It had originally just lapsed after 2022. They're also making efforts toward more effective financial benchmarking to make sure that high-performing MSSPs continue to enjoy shared savings and be clear of some of the ratcheting effects that makes those savings go away over the long haul. And also softening the glide path to full risk, observing that new MSSPs come live, often enjoy some savings, but bail out before they get to the higher risk levels. And so they're trying to keep those savings coming and keep that enthusiasm going. Now, health equity, as I said, is showing up broadly in 2023. First shows up as a new health equity quality measure in the MIPS measure menu. Also with a statement that health equity measures will now be considered high priority measures. It doesn't make a lot of difference anymore with the bonus, which is gone for extra high priority measures, but high priority and outcome measures are typically a requirement when you're selecting measures that you have at least one of those, and that will fill the need. There are 4 new health equity related improvement activities. Health equity MSSP twice, once as a health equity adjuster, adding bonus points to eligible practices quality scores, and also as part of the advanced investment payments that allow you to collect some money in advance on your anticipated to invest in taking care of your underserved population. And of course, Reach ACO, which is experimenting with different policies of improving health equity performance, starts this January 1st. A word about COVID. This year wouldn't be complete without talking about it. We're still in the nationwide public health emergency. And on October 13th, they examined it and extended again till January 11th. Looks like around that time they'll examine again and potentially extend it another 90 days. So we're waiting to see what happens with there. At the moment, they previously declared that the adjustments to billing, particularly the leniency on remote care techniques or codes and delivery will remain in place till the end of 2023 and could go longer. Now, so far they haven't announced another automatic EUC exception. That's extreme and uncontrollable circumstances. Twice in these last 3 years, they've announced it in the submission season, so it could be coming yet. But the applications for EUC, if you think that COVID is keeping you from performing and can make that case in an application, those are due by January 3rd. Now, the usual numbers, let's go through these fairly quickly. Each of these cases, I've included some kind of a chart that shows you the incremental changes over the years. You know, we're now in the largest and a stable theoretical differential from a negative plus or minus 9% adjustment with MIPS. Now that takes the plus 9% with a grain of salt, because by legislation, this is revenue neutral. So they take the money that they collect on the negative adjustment side, divide it amongst the winners, and so there's an adjustment factor. And current thought is it might be in the 3% range, the maximum positive incentive for the 2023 service year, which will become the 2025 payment year. Performance category performance rates, or weight, I should say. The pie chart on the left shows where it is now. It's at a stable quality at 30%, cost at 30%, improvement activities at 15%, promoting interoperability at 25%. And the bar charts to the right just show how that's progressed through the years. And this is the steady state. We expect it to be that permanently now. I think I'm expecting it to even go into the new MIPS when this traditional pattern goes away, and they're basing it on the MVPs. Performance threshold, that's the score at which everyone above that score gets a positive adjustment. Everyone below that score gets negative adjustment. That's now at a stable, relatively stable 75. Legislation just says the secretary has to base it on a prior year's mean or median, and they've chosen one of the most generous of those and selected at 75, and I expect they probably won't change it for a while. The other line here is the exceptional performance threshold, and you'll see it stops at 2022 because the year we're in is the last year that exceptional performance bonus is applicable. That $500 million that Medicare's kicked in, that would kick in at that score, is going away after this performance year, show up again in your 2024 payment year, but no longer in any of these performance years. Bonuses, they've been dropping those off steadily, and after the current 2022 performance year, we'll no longer get that exceptional performance bonus. They've already ended the high priority measures bonus, ended the end-to-end electronic reporting bonus. They're continuing, and I expect permanently, although who knows. Small practice bonus continues. Quality improvement bonus with a 30-point floor continues. They just added a cost improvement bonus, 1% for those who have improved cost year over year. Complex patient bonus, 5 points each for medical complexity and social complexity. So those continue. Now, categorically, let's just briefly review the changes in those categories. Sunset of the web interface for MIPS groups after this submission season for the current 2022 performance year. So you MIPS groups who are using web interface have to choose something different for years to come. And you know the alternatives. Feel free to give us a call. We're ready to help you. MIPS quality measures, the usual fiddling around with the quality measures, removing some, adding some, changing some specifications. Two important measures have been removed that a lot of people depend on. That's the flu and the pneumovax measures. That data is rolled into a adult immunization status measure. And the two individual measures are kept to be used in at least one MVP. But as far as traditional MIPS go, you'll only be able to use those in that roll-up adult immunization status. The inventory of measures goes down from 200 to 198. 76 measures have substantive changes to the specifications. They've moved around measures in specialty sets, redesigned those a bit. So I'm not going to go into that in any detail, but my typical advice is make sure you review those things you're counting on doing again. Make sure they still exist. Make sure the specifications haven't changed. Make sure you're recording the data you need to show your performance on those. So just don't take anything for granted. Make sure you're ready for the next year. Data completeness criteria stays the same at 70% this year or in 2023 as the two prior years. They've already scheduled it in to 75% for 2024 or 2024 and 2025, with the expectation it's going to continue going up. How I don't know. PQRS was at 80 for all the years it existed. My guess is we'll be heading in that direction ultimately. Measure types, nothing new on that. Just a reminder that by the previously established policy, measures in the typical run-in-the-mill MIPS submission are going to have the full run of 1 to 10 points, no longer have that 3-point floor. And there are no points for those that lack a case, that lack a case minimum or meets data completeness, but lacks either case minimums or lacks a benchmark. Except if you're a small practice, you still have 3, almost anywhere to measure, and at least one patient in that measure. And of course, reiterating what they said earlier, that the new measures will have these 2 ranges of scores depending on the year. Interesting change, they've declared that for administrative claims measures, those that Medicare calculates for you from claims, they'll all be scored exclusively against performance period benchmarks. No longer pre-publishing, so you know what you're going to get. I wonder whether that predicts ultimately going to performance year benchmarks for everything. It's really not rated on a curve the way they do it, but we'll wait and see. Certainly nothing breathed about that so far. A little alteration to the facility-based rules. Participants are now eligible to receive the complex payment bonus even if they don't submit data. That would mean that it would add to the quality points coming from the facility in which you're working. Also, virtual groups now eligible to be facility-based. In cost performance, cost measures expect to be solely developed now to support the MVP program. Nothing that's exclusive to the traditional MIPS program. Expect. Now, I'm not sure how this will come out in the wash. Certainly, they responded to my question by saying that traditional MIPS users will be scored against any available cost measure for which they meet case minimums. And that's how episode measures have worked in the past. You can expect that continue to work even with the new cost measures created for MVP. MVP will only be scored on the cost measures applicable to that MVP. Again, added a cost improvement bonus this year, which no one will experience because there was no cost score in this past year because of COVID. Also, a change in the status of the Medicare spending per beneficiary measure. Improvement activities. 4 new improvement activities dealing with health equity, modification to 5, removal of 6, PDMP, that is the review of the prescription drug, the scheduled drug prescriptions on your patients getting a prescription is no longer an activity. That's been turned into a required measure in improving interoperability. Oh, and likewise, my annual advice on this: make sure you check the activities you plan for this year. Don't assume that they're the same as last year. Specifications change. You have to be sure you're keeping the data required to be audit proof. Promoting interoperability. Automatic reweighting is being removed for nurse practitioners, physician assistants, CRNAs, clinical nurse specialists. They've also scheduled removal for the physical and occupational therapists, speech therapists, and audiology, clinical psychologists, and nutritionists. Clinical social workers, still no word on them, although they were just added back into MIPS eligibility, so they'll probably have a couple of years anyway before they're removed from the automatic list. I expect permanently that ambulatory surgical center, hospital-based, non-patient facing, and small practices will continue to have automatic reweighting of promoting interoperability. This is the year 2023 that you finally have to have the 2015 Cures Edition software, HIT software, in place and functioning for at least the duration of your 90-day reporting period. Whenever you choose to do that in 2023. So make sure you got it, make sure it's turned on, make sure you're ready to attest to that. There's been some rearrangement of those measures. Query of the is now required. Query of the prescription drug scheduled drugs is now required. Still, a single doctor, it doesn't have to be automated, doesn't have to be integrated with your EHR, just done at least once. They've expanded it to 3 and 4, scheduled 3 and 4 drugs, so a little bit more leniency there. They've given you a third option for health information exchange that's participating with an automated process or undersigning with a TEFCA compliant group. Also restructured the public health and clinical data exchange measures, shrunk the possibilities to just two, pre-production and validation being one, and the second being active production. Now, starting in 2024, you're only allowed a single year in pre-production and validation. After that, you either have to be in active production, go on to another one, or not be scored on for that next year. They've created a new point reallocation schedule, redistributed the points a little bit to leave room for the extra 10 that's coming from query of PDMP. And still the same unscored required measures like the security risk assessment, review of the SAFER guides, and the CEHRT levels. Oh, and also attesting to a lack of blocking, information blocking. Oh, and an interesting addition, that APM entities are now able to report promoting interoperability at that entity level, which is an interesting add-on to the APP, since you're going to be reporting, since you are and will continue to report quality at the APP level, APM level, you can report the promoting interoperability in the same time. MIPS phase. And line 23 with an interesting proposal to use this as a basis for the next MIPS. And this is Medicare's slide about the timeline for 2023, 24, and 25. We're in a period that's called voluntary subgroup reporting. So you don't have to use MVPs. And if you do MVPs, you don't have to report as a subgroup. For 2026 and 27, you don't have to use MVPs, but if you do, you have to limit it to those specialties that are eligible for the MVP. Because you have to have subgroup formation if it's applicable. Then after 2027, we're to mandatory MVPs with mandatory subgroup reporting. So that's what. Now again, that time frame is set in sand, non-concrete, but it is interesting to know that the agenda, this order in mind, in fact, something like that to be delivered. And just again, their slide showing the users eligible for MVPs. Any individual can choose an MVP. Any single specialty group can choose one MVP. A multi-specialty group, interesting, can be qualified just on a single MVP. It doesn't have to be applicable to all the specialties. You don't have to do traditional MIPS. You can do just an MVP. Any subgroup can do an MVP. Any APM entity can do an MVP. Now, subgroups inherit the special statuses of the parent group. That is low volume, hospital-based, non-patient facing, small practice. All those come from the parent group, are not applied. Those measures are not applied to the subgroups. The subgroup has to be able to submit the aggregated measures just with the applicable physicians. They have to be able to filter out everybody else. We're ready to do that for you, so give us a call if you want some help with that. Improvement activities must be performed by at least 50% of the clinicians in that subgroup for at least 90 days each. Doesn't have to be the same 90 days, has to be the same improvement activities. And cost, pop health measures and outcomes-based administrative claims will be analyzed at the parent level, not at the subgroup level. Here's the 12 MVPs that are available in the 2023 performance year. Medicare is upping its game on developing new MVPs and making lots of invitations to get broad participation in that development. Expect that to be their major project over these next several years, while we're watching that the end of traditional MIPS and movement into the new MIPS. Any one TIN NPI, that is an NPI working at one practice, that NPI can only participate in one MVP. Whether you're an individual, whether you're a subgroup, whether you're the entire group choosing to do it, just one. You can do both an MVP and traditional MIPS, and you can break into multiple subgroups in your multi-specialty practice to do multiple MVPs and traditional MIPS for everybody, or just MVP, but has to be just one MVP. You've got to register for MVPs. Registration is open from April 1st to November 30th. You can change your MVP anytime until the close of that period. Some MVPs include the requirement of caps or the option for caps. You have to do that by June 30th because of requirements and limitations. And if you register for an MVP, you don't have to do it. You can do just traditional MIPS. But if you don't change your MVP, if you haven't selected the MVP you want to do by November 30th, you can't change or add anything else after that. And there's a list of things you have to describe as you register for your MVP. Now to the APMs and the MSSP. To encourage new participation, they're adding an advanced investment payment for new low revenue MSSPs. That's an advance on your anticipated shared savings to be able to invest in infrastructure to better care for your disadvantaged patients. They're also working on encouraging continued participation by permitting a longer, slower glide path to full risk, changing the benchmarking to reduce the ratchet effect, and changing the sharing dynamics so that it's a little more smooth, makes sense, and perhaps a little bit more lucrative for you. Still planning to complete the sunset of the web interface for MSSP by after the 2024 submission year. Have to be on full ECQMs or MIPS CQMs by 2025. Extending the favorable quality standard for early ECQM and MIPS CQM users into the 2023 and 2024 years, and adding a health equity adjustment bonus based on the proportion of your practice that's disadvantaged. That adjustment's only available to people using the electronic or MIPS CQMs, not those using the web interface. A little more on the advanced investment payments, only available to new ACOs. Can't be renewing or re-entering. They have to be eligible to participate in shared savings, inexperienced with performance risk, and a low revenue ACO. That's typically excluding the hospitals involved in the care. It's only outpatient practices, or it could also be inpatient-based practices, but it excludes the hospital side of the care. Applications available in this coming year and to go in place for 2024. It provides $250,000 upfront, plus the getting with the $250,000 and that 8 quarterly payments of an amount based on the of disadvantaged in your patient panel. And again, you must use the you must use the funds to build infrastructure for your disadvantaged. Extending and softening the glide path to full risk. They've observed that people get into the first 5-year program and then tend to drop afterwards, even if they're successful with generating shared savings, concerned about that full risk. So now they're permitting 5 years at level A of the basic track in your first ACO participation period, and supporting a second that goes through the usual run of the tracks, and allowing you to stay indefinitely at basic track level E instead of going on into the enhanced track, and even to go back to level E if you're already in the enhanced track. So a lot easier in that regards. Also working on benchmarking to get rid of that annoying ratchet effect that you've got less chance of generating shared savings over time as you improve, and they're basing your benchmarks on previous performance. They're now blending a national growth factor with a regional growth factor and an accountable care perspective trend. That is what they expect from national numbers for you to increase year by year, and grading and giving benchmarking on that. Also providing an option for early renewal to get into that different blend, that different way of calculating, and also suggesting that may move to future administrative benchmarks, not so much based on a calculation, but a negotiated number that, again, rewards great performing practices with a continued chance of generating shared savings and not be out of that year to year. And there's been an interesting change in the dynamics over the last few years. Initially, prior to 2021, they had this sliding scale that started at the quality standard and went to 100% sharing when you hit the 100% perfect quality performance measurement. For the 2021 and 2022 years, they changed it to this pattern that you collected everything at the quality standard and no improvement with time, which benefited everyone it applied to, but created this kind of appearance of awkwardness with a cliff, with an enormous change over that narrow change from under to over, that 1 point under to over the quality standard. So they're altering it again starting in 2023 with this pattern that starts a phase in before the quality standard, and then everyone after the quality standard will share of the savings. So you can see that at every level that it affects, it's beneficial to the old, takes some of the pizzazz out of the increase that's coming in the 2024 year to the quality threshold. So this looks good for everybody. They're also, we've mentioned, you've probably seen it in the past, the same thing, but it's extended into 2023 and 2024 for a favorable quality standard for those doing MIPS or ECQMs. So for practices that are, for MSSP practices that are using the E or MCQMs, they meet the data completeness and case minimum for all three. If they achieve only a score of 10% on any of the outcomes measures in the APP set, and on any one of the other measures, earn a score of 30% or more for 2023, and when the threshold goes up in 2024, it becomes 40% or more on that. That abbreviated or threshold qualifies you for full sharing, and to get into that sliding scale below this threshold. So again, it's a fairly big improvement to go to early use of the APM and or to the APP CQM measures. Oh, and again, a reminder that only submitters of the CQMs, electronic or MIPS, will get the health equity bonus points of 1 to 10 if you earn that for the number of disabled or disadvantaged in your practice panel. About that health equity adjustment, non-adjusted scores will be used to calculate the performance standard and used to determine, but the adjusted score will be used to determine if the ACO meets the performance standard and the final sharing rates of savings or loss. The bonus will be added to the quality performance standard, capped at a score of 100%. And the bonus is made of two components, and I'll give you more of those details here. There's a measure performance scaler based, they calculate this adjustment for each measure. It's the score of each measure. Lowest third gets 0 points, middle third gets 2 points, upper third gets 4 points, and then multiply that by an underserved multiplier, which is a percentage of your patients who are either dual eligible or on Part D low income subsidy, or are in what's called have an 85% or higher score on the area deprivation index, which is a new measure based on census and census area groups, showing that the prevalent population in these areas have have inequities. That database is being maintained at University of Wisconsin and is available. Well, Medicare will be making that measurement, and some vendors can follow up on that as well. Now, just a quick glimpse into the future. Digital quality measurement was not mentioned at all in this final rule. So with a teaser that they were interested in getting the full digital quality measures by 2025, it really takes the wind out of those sails. I think the digital quality measures is more of a vision and a guide than it is a strategic plan. They're just saying it's desirable to have more measurement being digital. Traditional MIPS and MVP, again, not only are they planning that change from traditional MIPS to MVP-based MIPS, but they're also looking at ways to use MVPs as you're measuring specialties more specifically as a way to blend specialty care into the typical ACO or MSSP. So we're likely to see by the time we switch to full-time MVPs that there's a lot more interplay between MVP-based MIPS and the MSSP. Financial benchmarks. They're desperate to keep people interested in MSSP, participating in ACOs. So expect some kind of a simplification or recalculation of those shared savings calculations, so that high performers continually get opportunity for reward. And that I think covers it. Covers everything I planned to cover, and we're open for questions. Garrett?
All right. Well, we did have a bunch of questions that came in, and this was fantastic and so much information here. By the way, if we don't get to your question, don't worry. Someone will get back to you via email to answer your question. So if you have one, go ahead and ask it, even if we're wrapping up last minute. So, but in no particular order here, and we'll get to as many again as we can. The first one is, are social drivers of health screenings only going to be required for the acute inpatient setting, or will ambulatory settings also be required to screen for social determinants of health?
Well, at the moment, I'm not aware of any requirement for screening. There's rewards for screening, and that is invisible to the inpatient or outpatient environment. In fact, the MIPS program applies to both. So I expect to see it ramping up in both.
Okay, great. Next question is, are there any perspectives on what the positive adjustment is projected to be for PY 2022 paid in 2024?
Oh, let's see. Good question. It is the last year of the exceptional performance bonus. We've tended to come in around the 1.8% level, and it'll take some lift to get us to what they predict at 3.6 for the 2023 performance year. I'm guessing 2 to 2.5 is what you can expect for maximum maximum positive adjustment based on 2022. But again, that's just a guess.
Sure. Great. Next question. On adult immunization status measure, do you know if flu and pneumonia will have individual numbers, or will the score will the score be a combination of both?
Oh, well, those specifications are available now. I haven't studied them, but as uh, others of those measures function, um, the reported measures likely to be um, the number of patients fully immunized that have the indicated pneumovax, have the indicated flu shot, um, the shingles, um, uh, tetanus, pertussis, um, et cetera. But again, that's a good one. I'll check on that. I'm sure that's going to be a popular measure for people who are losing the pneumovax or flu. So we'll get a broader answer on that out.
Okay, great. Next one is just a clarification. It says, so to be clear, MSSP can still have practices that are not CEHRT, but MIPS must have a 2015 CEHRT?
Yes, you only, I think the standard is still that 75% of participants have to be using CHRT, and you only get credit for CHRT. It's only certified if it's certified to the 2015 cures standard.
Okay, great. Next question here is regarding promoting interoperability. Will small practices automatically get a PI hardship for 2023?
Yes. Um, yeah, all small practices. If you don't submit anything for promoting interoperability, you'll be your scores will be redistributed. Um, and if you do submit, then it'll erase the exception, and you'll get a score.
Very good. Next question, was fire referenced in the final rule, FHIR?
Um, no, only in kind of still working toward nowhere does it become a requirement um, uh, other than how it exists in the CEHR, the promoting interoperability side of things and the certification of EHRs. But there's no delivery that has to be made. I think the expectation is that if you're participating in one of the three methods of health information exchange, that FHIR plays a role in that. But again, it's not a requirement that everyone use that as a standard yet.
Great. Next question is, could you speak to the recent study published in JAMA that states the study calls Medicare pay for performance program results into question? MIPS doesn't consistently correlate with process outcome measure performance in primary care.
I no, I haven't read that, so I can't comment specifically on the message. But it does sound credible. It wouldn't surprise me that this basic level of reporting. I think we're still in the infancy of quality measurement and reporting, and selecting 6 measures for MIPS or 3 measures. Well, you don't get a selection assigned 3 measures through the APP. Or 4 through the MVP, it kind of pales beside the requirement for practice. Talking to my friends who are doing evidence-based medicine at an industrial level, there's perhaps between 30,000 and 75,000 rules that we should be following. So we don't get much reflection of those. And also, I think the way measurement is set up, it tends to grade your documentation and recovery a bit more than practice. But I think we'll see some improvement in that with time. I think it is important to put attention to improving your quality.
Very good. Next question. What will the hospitalist measures look like going into 2023?
Can't offer you any specific on that. There is a hospitalist, a specialty group, so I'd encourage you to go out to the QPP and pull that. If you're working with my staff, you can reach out to your consultant to help you work through that. The data is there in the QPP site.
Okay, great. And again, we're just going through these. We'll get to as many as we can. We have a bunch of questions coming in, so this is a good problem to have. But if we don't get to yours, again, we will get to it by email. So please ask your question. Next question is, if you are participating in an MSSP ACO, what is your MIPS requirement? Is promoting interoperability still required?
Again, repeat that question to me.
Sure. If you are, and I apologize in advance if any of these are maybe repetitive. So you may have already clarified this, but if you are participating in an MSSP ACO, what is your MIPS requirement? Is promoting interoperability still required?
Yes, promoting. You know, you stumped me on that one. You have to be using, and you have to be using the certified CEHRT. But I think there's a disconnect between being a qualified participant and a MIPS APM. MIPS APM definitely needs to provide a promoting, well, definitely is liable for that promoting interoperability score. So if you're in one of the lower levels of risk that's not above the nominal loss possibility, you come in as a qualified participant, and that's probably about a quarter to a third of all MSSP participants that are qualified. And I don't think they actually have to make a PI submission. But for the majority of MSP participants who are in the lower levels of risk, you do need to make for the best score, and you have to make a submission.
Good. Sorry to stump you on that one.
Oh, that's good. I love being stumped. Go ahead.
Well, you heard
all
him,
this
folks.
session, stump the chump. I'm the chump. You try to stump me.
All right. Next one is says on slide 45, you seem to use the terms ACO and MSSP interchangeably. Do those requirements apply only to MSSP ACOs, or would they also apply to REACH ACOs?
I don't have the same level of knowledge on the REACH ACOs, so I can't tell you which of those requirements. I was speaking really specifically of the MSSP ACOs. The REACH may have some differences. And I think you can look forward to a specific webinar on REACH in the near future.
Yeah, sounds good. Okay, we have a time for a couple more here, and unfortunately we'll have to wrap up. Next question here is web interface for reporting. Can you explain that? We are part of an ACO that has many different EMRs, and we are unable to submit an ECQM QRDA.
Right, and my recommendation is go right to MIPS CQMs. We've been doing that kind of work at Mingle Health for the last 10 years. We're very good at getting data from all of your participants and blending it. The methods that we pioneered 10 years ago are still working fine. We bring the data in from all the participants, we map and match the patients. We normalize everything in our database and then run our algorithms against that combination. And we've been dealing with thousands of practices every year, taking all comers as far as information systems go. And we have complete confidence that we can bring yours together as a MIPS CQM submission. ECQMs, you're going to leave you in the lurch. It's a very difficult process. Need to maintain it every year. If you're not right on their recommended documentation standards, it doesn't work. And nobody is, or very few people are prepared to take that combination, put it together in a single QRDA to submit. So my advice, you can do it easily and quickly with the MIPS CQMs. And you're in for heartache if you go ECQMs.
All right. Next question here is, says, with one of the last comments of Dr. Mingle that digital reporting was not discussed in the final rule, is he referring to ECQM or CQM being required by PY 2025 to replace web interface? Can you please explain further?
No. Medicare has come up with a strategic plan to that's called the digital quality measurement. It showed up in the 2022 proposed and final rules. It showed up as a strategic document, and I think it's been widely misquoted and misunderstood. In there, Medicare is displaying their preference to base the quality measurement on electronic data. So want to get data digitally. Now, ECQMs are electronic data, so ECQMs are digital quality measures, but they're not the only ones. They also say, what they're saying is Medicare would like to be able to tap in any digital data to make measures, like patient-reported outcomes, remote monitoring, registry data sets like tumor registry, or if there's a independent diabetes or hypertension registry. Any of these things should be fair game. There's plentiful mistakes in identifying that. Some people say, oh, that means they're going to only ECQMs, but that's not the case at all. To expand your ECQM provider to all possible digital measurements, they all have to dramatically increase their data capabilities. For a group like us, we already use any data that you have digitally. So if Medicare ever cuts out any of the manually entered data, we actually diminish our required annual data handling options. But we can already deliver on any of your digital data today.
Great. Well, with that, unfortunately, we have to wrap up. We do have a number of other questions that have come in, and thank you, everybody, for sending in your questions. Just know that someone will reach out to you with an answer to your questions, so don't worry. But this was a wonderful presentation. Clearly, there's a lot of interest in this topic, and Dr. Mingle, really appreciate your attention to all these details. This is a wonderful presentation. As we conclude, I wanted to encourage you guys, everyone who's in attendance here today, goodbye, Dr. Mingle, wanted to encourage you all today to visit the Salient Healthcare Exhibit Hall booth. And this is located at the vbcexhibithall.com. And this is where you'll be able to actually meet with the team and also learn more about what they're doing. And of course, if you would like to get in touch with either them or with Dr. Mingle or the Salient team or myself, feel free to reach out. We'll be happy to put you in touch with any of them. And finally, just wanted to thank you again so much for joining us today. We know you have a lot vying for your attention and appreciate you spending the afternoon with us. So keep in touch, and we'll be in touch with other webinars that are coming up. Thank you so much. Bye now.